Hello, my name is Dr. Daniel Petereit. I'm a radiation oncologist in Rapid City, South Dakota. I'm former president of the American Brachytherapy Society and currently chairman of the board. It's my pleasure today to share with you the ABS initiatives to enhance training the next generation of brachytherapists. The objectives are to discuss the current status of brachytherapy utilization. We'll really focus on current ABS strategies that include 310 next generation brachytherapy and the 2-month senior electives that we have developed, as well as virtual training platforms. Also throughout this, we'll discuss opportunities for residents and new brachytherapists in practice, including urologists. This really started to come to national attention probably back in 2015, and prior to that, where we published an editorial in the Journal of Clinical Oncology entitled Brachytherapy, Where Is It Gone? Paul Harari, former president of ASTRO, had an excellent editorial in the spring 2000 newsletter entitled Call to Arms. The problem, declining use of brachytherapy. The reason, multifactorial, but substituting IMRT or SBRT for brachytherapy is a major contributor. The pipeline in serious jeopardy as a majority of residents identify low brachytherapy volume as the greatest barrier to achieving brachytherapy independence. The result, diminished cure rates for patients with cervical cancer, and for prostate cancer patients, limited treatment options as well, in addition to lower cure rates if not utilized for intermediate and high-risk disease. Just to share some of this data with you, this came from Martin from Cancer. This is the rise and fall of prostate brachytherapy, use of brachytherapy for the treatment of localized prostate cancer, and this is taken from the National Cancer Database, in which over 1.5 million men were surveyed between 1998 and 2010. As you can see, for the low, intermediate, and high-risk patients, there's definitely a decline in brachytherapy utilization, either as a boost or as primary therapy. What are some of the causes for this? Well, one reason is that there's other competing modalities. Certainly, there is the ongoing role for active surveillance, which was very appropriate for many well-selected patients. A major contributing factor, surgery is obviously an excellent choice, and this data again comes from Dr. Martin as well. These slides are courtesy of Dr. Peter Oriol. But since the FDA approved the robot in about 2000, there's been a steady incline in the use of robotic surgery, which again is a very appropriate option for many of our patients. At the same time, there's been a steady decline in the use of a lot of the radiation options, especially brachytherapy. Same data now. Here we're seeing an updated version of this from Dr. Oriol that was published a few years later, looking at rates of robotic prostatectomy utilization over this time period, declining use of radiation. If we look at this for high-risk patients, we see the same trend with surgery being utilized for high-risk patients and a decrease in the utilization with radiation. This is an interesting analysis that came out of JAMA. This is a retrospective series of nearly over 1,800 men looking at prostatectomy versus the combination of external beam and a brachytherapy boost. This would be probably hypothesis generating, but in this very well-controlled cohort, there was certainly an improvement in prostate cancer-specific survival and a reduction in distant metastasis in those that underwent the combination of brachytherapy and external beam versus a radical prostatectomy. Radiation modality by risk group. Again, utilizing the NCDB, this is now another analysis by Dr. Oriol looking at these same trends with decrease in brachytherapy utilization, either brachytherapy alone or as a boost for higher risk patients. By high risk group, this is now the high risk patients in this cohort. We wouldn't expect to see brachytherapy used alone for this patient population, but certainly the combination approach, we see more IMRT being utilized and less combination therapy, again, from the same database. How about, are we prepared to teach the next generation of residents? Here we see the number of centers performing brachytherapy, academic centers and non-academic centers over this time area. we see that there's a reduction in the number of institutions performing brachytherapy, but really troubling is the number of academic centers that are training our residents to give the residents the opportunity to utilize this invaluable treatment tool. How about the number of cases per institution? This in the top graph here looks at those centers performing more than 12 cases per year or greater than 1 case per month. Here's a number of cases performing more than 1 case per week. So again, a very disturbing trend is documented by Dr. Oriol that our universities and academic centers do not have the volume to get patients to get the radiation oncology residents to that level where they're comfortable with brachytherapy independence upon completing their residencies. Same theme. Now we're looking at the trend of SBRT and SRS. There is a continuous increase in residents being trained for this, which is a critical modality for brain metastasis, SBRT for early stage lung cancer. And the bottom line is we're seeing more and more residents who are comfortable with utilization of SBRT and SRS, but less and fewer brachytherapy cases. This came out in JCO now 4 years ago, and these were the ASCO guidelines indicating that based on the data available at that time, that a brachytherapy boost with either HDR or LDR should be offered to men with intermediate and high risk disease. For those men with low and intermediate risk prostate cancer, LDR should at least be discussed as an option. And at that time, there was no recommendation on HDR, but we certainly know that HDR's monotherapy in 2 fractions is another appropriate treatment. So definitely getting on the radar screen beyond the field of radiation oncology as far as medical oncologists and others. I live in a remote part of the United States. I'm in western South Dakota. Prostate brachytherapy is an integral part of treatment options for many of our patients. This is a gentleman I treated. I live out in western South Dakota in the Black Hills. We serve about 70,000 American Indian cancer patients, and this is where a lot of our patients with advanced cervical cancer come from. And those gentlemen with prostate cancer, he lives up in the Cheyenne River Reservation. He has no means of transportation, and the only option for this gentleman was prostate brachytherapy, which he actually did quite well with. So it does, with the one treatment option in many parts of the country that are rural, this does address the issue of geographic distance from the cancer center. Obviously, these patients could be equal candidates for a radical prostatectomy. Well, what about our neighbors in Canada? While there's been a reduction in brachytherapy utilization, in Canada, it's been just the opposite. This came out in 2020. This was the proportion of patients, or the brachytherapy utilization had doubled over this time period. The HDR boosted increased 28% per year. And in 2017, 20% of the radiation cases received a brachytherapy boost. And this is broken down from the Sunnybrook Institution for HDR boost, monotherapy, HDR salvage, and LDR monotherapy. So this in Canada is a critical part of their treatment armamentarium. Randomized trials demonstrating the efficacy of a brachytherapy boost. There are 3 randomized trials. We'll get into the ASCEND-RT trial in a little bit, but there's plenty of data demonstrating the efficacy when used appropriately. And this is the most commonly, this phase 3 trial we want to discuss for a little bit, the ASCEND-RT trial. This particular study was a randomization. They looked at patients with intermediate and high-risk prostate cancer. Both groups received 12 months of ADT. One group had dose escalation with external beam or IMRT. The other group received dose escalation with an LDR boost. What we see is for the intermediate and high risk and overall, when you look at the patients, that there's an absolute difference in biochemical control rates up to 10 years. And this has been durable. Now, there has not been documented, they have not demonstrated an improvement in survival, but the patient numbers weren't large enough to justify that or to demonstrate that. The criticism of this trial is there was about an 18% risk of urethral strictures, but the prevalence really dropped down to about 6%. What's not reported in this trial are the life-term toxicities for those patients who had a recurrence, those who were treated with prolonged ADT, who had additional systemic therapy. And many of us would argue that the toxicity of a failure is often underreported. And also when we look at long-term survival, if we did have the numbers in this trial, I think there would have been an improvement in survival. But the question now comes up is that rate of urethral toxicity actually that high? And so I would say it's a fair statement that LDR boost for intermediate high-risk patients provides higher rates of local biochemical control, but it is at a greater cost of GU morbidity compared to an IMRT boost. Can we do better? What about using an HDR boost versus an LDR boost? And recent discussion I've had with Dr. Juanita Crooks, who's also one of the speakers for GRU, when they look at their data with an LDR boost, the toxicity rates as far as urethral stricture are less than 5%. And we'll get into what are some modern planning techniques to get down that rate of long-term toxicity. A lot of people have switched over to an HDR boost because there's some advantages, including inverse planning and more consistent dosimetry. We actually do the plan after we put the catheters in, inability to cover extraprostatic disease. There's a different radiobiology that may be more in favor of an HDR boost, although I think LDR is still appropriate. There's issues of radioprotection where there's really no radiation to the staff when we're using an HDR boost. In some systems, it may be a little less costly, and there's greater flexibility for focal or ultrafocal treatment. This was a terrific editorial that was written by Dr. Gerard Morton entitled High Dose Rate Brachytherapy in Localized Disease. Why do anything else? He had a terrific single institutional analysis on 500 patients treated with external beam radiation and a 15-gray boost. These were for intermediate and high-risk prostate cancer patients. Similar to the SEND-RT trial, the biochemical control rates were very high, but the rates of urethral strictures were really only about 3 to 4%. So when we look at their data compared to the SEND-RT trial, there was a 4% rate of urethral toxicities. This is another data set. This was a phase 2 clinical trial through the RTOG published by Joe Shu, looking at external beam radiation with an HDR boost. But their rates of urethral strictures at 5 years was about 4%, a little bit higher at 5% at 10 years, but certainly much lower than the ASCEND-RT trial. What about MRI-assisted radiosurgery for LDR? Dr. Stephen Frank has really pioneered this planning technique to reduce toxicities. The rationale for MRI is it's better than ultrasound and CT in delineating the organs at risk during brachytherapy. We can identify the intramembranous urethra and the external urinary sphincter, and there's actually dose constraints now that have been published. This is just an example of the EUS on an MRI that we can easily identify compared to an ultrasound, which is more challenging. This is one of our LDR prostate brachytherapy cases where we were able to fuse the MRI to the ultrasound, identify the EUS, and that became a dose-limiting structure. So in this particular permanent seed implant, this was a monotherapy case, we were able to clearly identify the EUS and to minimize the dose to that structure to ultimately reduce the dose or the risk of a urethral stricture. This is some current dose constraints when using LDR brachytherapy, when we're utilizing MRI fusion. Again, the bottom line is better identification of the organs at risk, reduction of the dose to those critical structures, and hopefully a reduction in urethral toxicity rates. Interestingly, this came out not too long ago. This was an analysis of 14,000 patients who had undergone brachytherapy at 7 institutions. We now have a brachytherapy definition of a cure. And when you look at this data, if patients get out to 4 years after brachytherapy, whether as monotherapy or as a boost, and their PSA is 0.2 or less, their recurrence rate after that is less than 1 to 2%. So there are the ASTRO and the Phoenix definitions of a biochemical failure. In the brachytherapy world, this is our definition of a surgical cure when brachytherapy is utilized. So for LDR prostate brachytherapy, indications would be as a boost with external beam for intermediate to high-risk disease. Could also be used. One could also use an LDR boost as monotherapy for low to intermediate risk patients. We're now seeing data emerging that brachytherapy can be very effective as salvage for local recurrence following external beam. And there's certainly another option for these patients who have had an IMRT failure. Now, what are the barriers to brachytherapy utilization? This was a passion and kind of my mission when I took over as president of the ABS in 2019. We talked about these initially. These include inadequate resident training, low brachytherapy practice volumes. For a lot of residents, it's easier to do IMRT and SBRT. However, survival is significantly compromised for patients who are treated that way with cervical cancer. We do know that with the combination approach for intermediate to high-risk prostate cancer from the ASCEND-RT trial and other data sets, the rates of biochemical control are much higher. Other barriers to utilization are brachytherapy is complex and time-consuming. There's Medicare reimbursement issues that may disincentivize physicians. We're in the middle of the APM model. There are some scenarios where brachytherapy will do better. There are some other scenarios where it may be a disincentive. Our views are often linked to reimbursement. There's a fear of an NRC violation, especially when performing LDR prostate brachytherapy. Well, what are some of the solutions? That's really what I wanted to focus on. Really, this starts in the radiation oncology residency programs. The most dramatic decline in brachytherapy utilization was at the academic centers. This needs to be a high priority for program chairs. Hire competent brachytherapists, ABS initiatives that we'll get into in just a moment. This will be an ongoing challenge if residents aren't properly trained. Some of the mechanisms we have in place are annual meetings, our brachytherapy schools. We'll talk about the 2-month senior electives. Dr. Oreo and others have done a national campaign to increase public awareness. If we look what happened at the Seattle Prostate Institute in the 1990s, they did a tremendous job in getting the word out to the public, increasing public awareness, increasing the demand. This is from Dr. Oreo, where we had a national campaign with Rob Lowe, who is our moderator, where we featured patients who had undergone prostate brachytherapy that did well. We have done this for breast cancer, cervical cancer. In the world of cervical cancer, although we're mainly just, presenting this, our platform to the urologists, it's a travesty if cervical cancer patients don't receive brachytherapy because their cure rates are markedly diminished. This comes from our ABS website, where we have a section in here that talks about the value of brachytherapy for patients. So our big initiative starting back in really 2018 was 310. And the goal is to train 30 competent brachytherapy teams per year over the next 10 years through a 6-phase approach. It's really a 5-year strategy, but this is where the 310 comes in. This is called 6 phases to establishing brachytherapy competency, and this has been going on for probably now 3 years. Part is to develop a national brachytherapy curriculum. We have many of our ABS members who are working on simulation-based training. We have this part of our schools. We'll talk about the 2-month fellowships, a designated ABS certified center. We will eventually go through some type of a certification process, but I want to dive into some more of the details. Dr. Stephen Frank and others have been critical in conducting 3 LDR, HDR prostate workshops. These have been conducted in Chicago, Denver, and in Houston. The premise of this workshop is there's a lot of hands-on training. This is an example where these teams that people that come in that include radiation oncologists, physicists, and radiation oncologists, they go through LDR simulation, computer simulation, a lot of hands-on training of using phantoms. So that's been, I think, a very valuable part of the teaching for people that have come through our training courses. With these workshops, we have trained 130 teams. And interestingly, and this was published in the Journal of Brachytherapy last fall, about 80% of those teams that have come through for the prostate brachytherapy workshops, they've implemented a brachytherapy program within 6 months of the school. So in a sense, we're really kind of halfway there, or more than halfway there, when it comes to training competent brachytherapy teams, and we're doing the same thing for cervical cancer. Next Gen Brachytherapy is a mentorship program that was started by Ivy Franco and Lisa Singer out of Harvard. This is a early career mentorship program. This grew from discussions that we had at our ABS meeting in Denver of 2019. But the program goals are to provide opportunities to discuss brachytherapy cases and applications, to create a forum for discussing early cancer challenges, career challenges, and creating opportunities for career growth and networking. We have 20 mentors as of now, and so this program is up and running and could be a valuable program, especially during COVID. We also have some virtual reality training going on through Dr. Neil Tunk at the University of Pennsylvania using these virtual Google glasses. We do we've done a lot of training or educational opportunities with these virtual education platforms. Many of these seminars that we have are available on YouTube. Grand Rounds in Urology is obviously a critical part of this to reach out to our urology audience. These are the goggles that all ABS members are receiving as part of Next Gen Brachytherapy. I think one of the most important part of 310 is these 2-month electives. And so a resident can, basically become competent with all the book work, with all the virtual training as possible. But the problem is, unless they have hands-on experience, I think it's really going to be a barrier for them implementing a brachytherapy practice. ABS piloted this with Dr. Brian Moran with the 3-month fellowship for LDR prostate brachytherapy in Chicago. But as of now, the ABS has identified 22 institutions. They're equally distributed between GYN and prostate. Within prostate, LDR and HDR. Eligible candidates are PGY4 and PGY5 residents. We hope to go live with this in the summer of 2021. We've been on hold for a year due to COVID, but this will be part of a certification process that the ABS will have with the residents. Interestingly, this story was published by Jill Remick and Sushil Barrawal in Brachytherapy, where Dr. Remick talked about her basically 2 to 3 month experience with Dr. Barrawal doing hands-on training. And this is the same model that we're talking about with these senior level residents. So when they complete these hands-on experiences, hopefully they'll feel competent to initiate a brachytherapy practice. On behalf of the ABS, I want to thank you for your time, and it's been a pleasure to be a part of Grand Rounds in Urology. Thank you.